Welcome to this presentation designed for patients who have been identified as being at increased risk for the development of breast cancer. You may have been identified through several processes, including getting a screening mammogram or having family history or genetic testing through your primary care or gynecologist office. In that process, you were identified as having an increased lifetime risk for the development of breast cancer. How did this happen? What does it mean? What do you need to do next? I am sure many more questions came to mind when you were contacted and referred for evaluation at the Excela Health Breast Center. Hopefully this video will serve to answer many of those questions and give you a starting point for discussion with your surgeon. Let us first begin by defining risk. In the United States, women have approximately a 12% chance of developing breast cancer during their lifetime. Women who are found to have greater than 20% lifetime risk of developing breast cancer are considered high risk. Elements in your personal and family history can affect this, and these are typically the questions that were asked at the time of your screening mammogram, as well as by your physician. So what are these personal risk factors? The risk of developing breast cancer tends to increase with age, but as you approach age 80, this tends to taper. The earlier onset of your period and the later onset of menopause tends to increase the risk because of exposure to the body's own estrogens. Likewise, the use of hormones such as estrogen and progesterone after menopause may increase the risk. The use of birth control containing estrogens likewise increase risk. We tend to think that early childbearing may offer relative protection from developing breast cancer. Additionally, breastfeeding may be protective as well. Surgery itself does not increase risk, but multiple previous breast biopsies would suggest that the individual may have some underlying breast process that can lead to increased risk. Obesity and decreased physical activity are likely related. Fatty tissue can produce estrogen, and this may be a factor for increased risk. Alcohol use has been associated with an increased risk for breast cancer as well as other cancers. Previous chest wall radiation is associated with an increased risk of developing breast cancer. Women with very dense breasts may have an increased risk of developing breast cancer. Additionally, dense breast tissue is more difficult to evaluate both clinically and by imaging. Therefore, this can be an independent risk factor. Many of you have been referred as high risk based on density of the breast tissue, limiting the sensitivity of screening imaging studies. 3D mammography is the most appropriate imaging study for breast cancer screening. If, however, a screening mammogram is abnormal or limited, additional imaging studies such as a diagnostic mammogram, ultrasound, or MRI may be requested after consultation with a breast specialist. Many of you were referred to the breast center for evaluation because of dense breast tissue. Women with dense breasts have both an increased risk of developing breast cancer, and dense breasts make imaging more difficult. These patients may require further imaging studies. This is a medial to lateral image of a left breast that is mostly fatty replaced. At the upper end of the slides, we will see some densities that represent lymph nodes adjacent to the underlying muscle. This shows a view of a right breast taken from the top downward with multiple scattered fibroglandular densities. This slide again shows a medial to lateral image of the left breast with heterogeneously dense breast tissue and some benign appearing calcifications. You can certainly see how much more difficult this may be to evaluate and why additional imaging may be requested after screening. This slide shows heterogeneously dense breast tissue. In the lower aspect of the breast, you can see some calcifications that prompted additional imaging. An ultrasound image of the lower inner aspect of this left breast does show a density that raised concern because of its irregular outline and it being oriented vertically. Even more surprising is what is revealed by MRI of that same breast, showing multiple areas of concern throughout the rest of the left breast. Compare that with the normal appearing breast on the right. Family history also plays a role in assessing relative risk. Having a first-degree relative, such as a mother, sister, or daughter, with breast cancer may increase your risk of breast cancer. And because we inherit half of our DNA from our fathers, there are some genetic disorders that can be passed through the father's family that increase the risk of breast cancers. Other risk factors, such as ethnicity and religion, can increase our risk of developing breast cancer. For instance, people of Ashkenazi Jewish heritage have an increased risk over the general population. Family history of other cancers can be associated with breast cancer as well. These include family history of ovarian, pancreatic, and prostate cancers, as well as other identified genetic disorders which may be discernible from the family history. So why are you at risk? It may be any or all of these factors. During your screening, you were asked to fill out a survey regarding personal risks and family risks. The imaging findings and/or limitations may also have placed you at a higher risk category, as noted previously. The risk assessment utilized by the Excela Health Breast Center is the Tyrer-Cuzick model. It is a validated, computerized model developed by English physicians that utilizes both imaging, personal, and historical factors to determine risk. It is very important for you to accurately report family history in order to get an accurate and useful risk assessment. As noted previously, normal risk for the female population would be about 12.5% lifetime risk. Women with a lifetime risk estimated at 15 to 20% are determined to be at intermediate risk. If the risk is determined to be greater than 20% lifetime risk, these women are felt to represent a high-risk category and deserve additional imaging that would not be typical screening images for the general population. They may also require closer follow-up. This is a screen capture of the Tyrer-Cuzick computer model showing the multiple variables that go into calculation of the lifetime risk. Note that this number may change over time as personal and family history changes. Before you meet with the medical staff at the breast center, talk to your relatives and get as thorough and accurate history as you can. We will be interested in the age that various relatives were diagnosed, their current age or the age when they passed away, what type of cancer they had, results of genetic testing if they had it, and some details of their treatment. The most important thing to know about being at high lifetime risk is that you do not currently have breast cancer. It is also important to realize that although your lifetime risk may be greater than 20%, a significant number of people with such risk will never develop breast cancer. However, you should have additional imaging recommended based on the limitations of typical screening. This could lead to potential for biopsy, which may be surgical or non-surgical. Thereafter, you at least require regular and close follow-up, again using techniques that are not typical for screening the general population. What additional imaging is appropriate? This may be simply a focused breast ultrasound in an area of concern based on the screening images. This is typical for evaluation of one of the scattered fibroglandular densities that were noted on one of the previous mammographic images. Some women with very dense breasts may benefit from whole breast ultrasound in addition to yearly 3D mammography. Some women in the high-risk category may benefit from yearly or intermittent screening MRIs. You and your physician will share decision-making to come up with the right plan tailored for you. Once a biopsy is performed, high-risk pathology may be identified on the specimen. Many of these are included on the slide. You may have had one of these identified on a biopsy that you had performed. When one of these is identified on a needle biopsy performed with image guidance, Typically, a surgical biopsy or lumpectomy is requested to remove the area of concern. This is done because of the risk for what is called sampling error. The biopsy may be high risk but benign. However, in the same area that may have not been sampled, a more significant lesion may be present and require additional treatment. Some of you may be referred for genetic testing, which may guide future therapy. So who requires genetic testing? That decision is based on acquisition of an accurate family history. Family histories with multiple relatives who have had breast, pancreatic, or ovarian cancers may suggest a genetic process is present. Other cancers, such as thyroid and colon cancer in your family history, are also taken into account. Certainly, when multiple family members present at a young age with breast and ovarian cancer, the concern for genetic changes is raised. Additionally, all women with newly diagnosed breast cancer may be considered for genetic testing. BRCA is probably the best known genetic change associated with breast cancers. However, there are many other genes that we are interested in, and this will be discussed at your appointment. The results of genetic testing will help guide our recommendations for preventative strategies and early diagnosis strategies. These may include lifestyle modifications, hormonal-guided therapy, and even surgery in a minority of patients. So who needs surgery in this high-risk category? As noted previously, high-risk pathology may require surgical excision to be sure that there was not a sampling error. In addition, a benign biopsy that does not match the imaging may require surgical excision for that same reason. Basically, this means that if the radiologist interpreting the images is concerned that the lesion is potentially cancerous, but the biopsy is benign, they would call the biopsy discordant and recommend surgical excision. Some patients who are at high lifetime risk for breast cancer may choose prophylactic surgery to remove the breast. This is certainly recommended in the population with BRCA mutations or other genetic disorders that place them at high lifetime risk for breast cancer. One option for management of the high-risk population is the use of chemoprophylaxis. Previous studies had shown a decreased incidence of the development of invasive breast cancer in patients prophylaxed with anti-estrogen therapy based on high-risk pathology or strong family history of breast cancer. This is not chemotherapy. Anti-estrogen therapy had been one of the staples of adjuvant therapy following breast cancer surgery. In that population, a decreased incidence of recurrent invasive breast cancers was noted. When studies were done on a high-risk population based on pathology or family history, that group also noted a decreased incidence of invasive breast cancers. What about children? Once we have assessed your risks, we may suggest your immediate family members are assessed as well. We will be able to guide you and your family once we have thoroughly evaluated you. Follow-up for women at high lifetime risk for breast cancer, greater than 20%, requires frequent examination. Yearly mammography may not be helpful in dense breasts as noted. Yearly MRI may be indicated. As described, however, some people may not be appropriate candidates for this. Whole breast ultrasound as an adjunct to mammography may be beneficial in that population. We have a dedicated team of medical and surgical doctors and caretakers who will be assisting you through this journey. But at the center of the team is you. You are here because you recognize some risk and sought to mitigate that with screening examination. Self-awareness regarding any changes is helpful. The rest of us remain prepared to evaluate and advise on a regular basis. You may be meeting with one of the surgical members of our breast care team shortly. Hopefully, this presentation has given you some background information that may facilitate that visit and guide your discussion. Thank you.